We have two speakers for this next hour. Carl Doghramji is a professor of psychiatry and human behavior and professor of neurology at Jefferson Medical College of Thomas Jefferson University in Philadelphia, and also the medical director of the Jefferson Sleep Disorder Center at Thomas Jefferson University Hospital in Philadelphia. His brother Paul is co-founder of Brookside Family Practice and Pediatrics, a affiliate of Pottstown's Medical Specialists in Pottstown, Pennsylvania. And together they are going to talk to us on restless legs. So please be on your best behavior. You are being recorded, so get your Tums or something out if you need to. Thank you.
Thank you.
Thanks very much. Great to be here with all of you today. Actually,
want some water?
Yeah, please. Thanks, Paul. As we speak about restless legs, before we start, I just wanted to make a couple of announcements. My name is Dr. Carl Doghramji, of course, and next to me is Dr. Paul Doghramji, not to be confused with Carl. By the way, some people think he's my brother and never met him before. Just saw him on the airplane today for the first time.
I'm going to tell Mom.
A couple of quick announcements. This symposium is jointly presented by the California Academy of Family Physicians and the Asante Communications Incorporated, or LLC, and supported by an educational grant from UCB Incorporated. We thank them for the support. The California Academy of Family Physicians policies on faculty disclosure, along with speaker disclosures and so on, are available in your syllabus. Please memorize those. And please take the time to fill out your pre-activity questionnaire if you don't mind. There'll also be a post-activity questionnaire. Those are in your actual, I believe, right in front of you. If you don't mind filling those out, I'd appreciate that. And again, as a reminder, if you could all turn off your cell phones and pagers and so on and so forth. Great. Any questions? So let's get started. Ready, Paul?
I'm ready when you are.
Now that's me, and that's Paul.
I look better than you.
See. These are disclosures, and the educational objectives for this talk are available in your syllabus, so please feel free to refer to those later on, if you'd like. So I'd like to talk a little bit about the diagnosis and the workup of restless leg syndrome in the primary care setting. First of all, what is restless leg syndrome? Restless leg syndrome is a disturbance characterized primarily by a host of symptoms which are located on this slide. People come to you complaining of various things. For example, I feel like I have something going on in my legs. It could be a pain. It could be an unusual sensation of feeling. Some people say, I feel like I've got to move my legs. Some people say I have this bubbling feeling deep inside my feet or legs. Some people say I have this electrical charge inside my legs. But what's common to all of these folks, regardless of how they feel, is this urge to move their extremities. It's really an urge. It's a sensation of having to move your legs to keep them happy. So urge. And urge also describes this, so mnemonic, which is very characteristic of restless leg syndrome, URGE, so an urge to move the legs, usually associated with these unusual feelings. Number two, rest induces these symptoms, so these are the folks who can't sit down like you and sit down for more than 5 or 10 minutes at a time without actually having this urge. Number three, activity gets them some relief, even though it may be temporary. So these are the folks who are walking behind, usually in the back of the lecture hall. And number four, evening time or the evening or nighttime makes these symptoms worse. So there's a circadian variation or chronobiologic variation. So worse in the evening versus in the morning or the afternoon. So those are the hallmark symptoms of restless leg syndrome. Now there are some ancillary symptoms or secondary symptoms which occur not in everybody but in most patients. Number one, they almost always have a positive family history if it's primary restless legs. And we'll talk about primary versus secondary in a second. Many people believe that this is a diagnostic hallmark, response to dopaminergic therapy. Almost all of these folks are exquisitely sensitive to dopamine-containing medications. Periodic limb movements in sleep, I'll talk a bit more about that in the next couple of minutes. Variable clinical course, we'll discuss that, and sleep disturbance. That's why many of these folks come to us, Paul, in primary care settings, especially complaining not so much of restless legs, but complaining of insomnia. And really what they had all along was restless legs. We just maybe didn't even ask them or be able to elicit those symptoms accurately. And of course, their physical evaluation usually is normal. Let's talk a little about their symptoms in terms of frequency. You can see that the most common symptom they report, about 43% of them, is sleep-related problems. They can't fall asleep, they can't stay asleep, they go to bed, their legs bother them in some way, and they simply cannot relax and go to sleep. But this uncomfortable feeling is a second symptom, pain. Some of these folks masquerade as chronic pain patients. They can't sit still, they have this urge to move, as I said before. Inability to get comfortable, fatigue. Fatigue is a big one, and I think restless legs should enter the differential diagnosis of chronic fatigue or even acute fatigue syndromes. Twitching, daytime sleepiness, and some people just don't have any stated troublesome symptoms. So these are the most common hallmark symptoms that these folks present with. And here again, to summarize the most common ones, insomnia, daytime sleepiness, but cognitive impairment. They don't sleep well probably, but whatever the cause is, they simply can't think well. Their thinking is not accurate, it's not normal. They lose track of things, maybe mediated by poor sleep. And the last one, quality of life. I mean, what is that all about? Well, you know, imagine having restless legs and not being able to sit still. I had a patient, a psychologist of all things, who would sit down and treat people. By sitting down was part of his profession. He would sit down in front of people, but couldn't do so for more than 10 minutes. Because he would have restless legs, so he'd get up in front of his patients, walk around in the room, and ask them to continue speaking, but he just could not sit still. He'd go out to breakfast with his wife on Sunday mornings, and they would go to the restaurant, order breakfast. He would, after ordering breakfast, get up and walk around the block a couple times, come back, finish his eggs, go walk around the block, then come back and finish his coffee. He just could not sit still and think about the quality of life that may have caused with him and his wife. He couldn't lie in bed long enough to be able to have intimacy with his own wife. So quality suffers with these folks either because of the restless legs or because of the fatigue and the poor cognition that this produces in their lives. Now, it's a chronic disease. It doesn't go away in most patients. And this is a summary of some stats on this condition, both in primary, I apologize, both in young age of onset and older age of onset restless leg syndrome. You can see on the left-hand column with the younger age of onset, the biggest distinction between these two columns is right here, family history. So the younger you are, there's a greater likelihood of a positive family history and for the disease to be primary in nature. Primary meaning not related to underlying other causes. But the most important thing on this slide is a look at this. The folks who say, my problem got more severe over time, 68% say that the problem increased in severity as I got older. And they say that the problem increased in frequency. Initially it was once a week or twice a week, but now it's like 4, 5, 6 times a week. So it has a chronic, unremitting course, often an exacerbating course over time. Now, this is where we do a little bit of ARS. You all have your clickers. So let me ask the question. Among your patients in primary care, now you have to be honest about this one, have you ever diagnosed restless legs? Have you ever once diagnosed restless legs? 1 is yes, and 2 is no. Let's vote.
Can we tell if they're being honest, Carl, just by how they're...
There's no honesty button. Yeah, we should have a third one. Are you dishonest or honest? Good for it. 90% said yes. That's great. Wonderful. You have diagnosed restless legs. And 10% of you said no. Shame on you, because that's a very common problem. Hopefully you'll learn more about it today. But let's talk a little bit about diagnosis. What is the positive hit rate with restless legs? If all of us were in the room doing this examination, evaluation of a typical patient, how likely are we to properly diagnose RLS? Well, in this one study of patients with multiple symptoms, only 13.6% were accurately diagnosed as having restless leg syndrome. The other ones were diagnosed as having all sorts of other conditions as the primary diagnosis. Another study, and this study, by the way, was one which involved doctors from many parts of the world, Germany, France, United States, and so on. So restless leg syndrome is often underdiagnosed or misdiagnosed as being something else. We're not very good at diagnosing restless leg syndrome, unfortunately, as physicians. And one of the problems, of course, is that people don't report it to us. Many patients don't recognize restless legs as a symptom. You know, just imagine your legs are jumpy. You really don't go to a doctor typically saying, I'm jumpy. You know, you go to a doctor if you're hurt, if you're painful, but the jumpiness doesn't take you to a doctor. And people don't quite know how to describe the symptoms. I had one person who said, Doc, I'm not quite sure what it is, but it feels like soda pop deep in my veins. I'm not quite sure what that feels like. I never had soda pop in my veins, but they just don't have words to describe the syndrome. So if you sort of don't ask them, they're not going to tell you in most cases, other than having some of these screen symptoms like insomnia and daytime sleepiness. So if you're going to ask about it and get a positive hit rate, the two things you probably should ask about are A, do you have problems falling asleep or staying asleep? And number two, do your legs keep you from doing that? Now you can ask this complicated question here if you'd like to. You get a lot of positive responses. It's a very sensitive question, but you're not going to ask that big question typically, most of you. What I do is I say, how are your legs when you sleep? How are your legs when you go to bed? Do your legs bother you in any way? And then you can refine the question as the answer goes along. Paul, what do you do? I mean, is that kind of what you ask? That's what I do.
Yeah, I mean, what you said earlier is about tiredness. People come in saying they're tired, okay? To us in primary care, they may not say, I have trouble sleeping or legs or whatever. And if they say they're tired, then asking those two questions are very, very important because they can go to that third question, do your legs bother you and cause you trouble sleeping?
Now the prevalence of restless leg syndrome, the true prevalence, it's a pretty common condition. If you look at restless legs of any frequency and severity, I mean, people saying, I get it once a week, it's minor, it doesn't bother me so much. It's pretty common, but that's not really a true disease. I mean, 13% of the population have that. But you don't want to treat that necessarily. But if you look at restless leg sufferers, these are people who have a very frequent problem with restless legs, and it causes significant debilitation in their lives. These are the folks who are falling asleep in meetings. These are the people who can't sleep all day and all night. These are the people who can't think well. Their cognition is suffering. These are people getting depressed over time. That is about 5.8% of the population. So it's not a trivial proportion. I mean, if you ask yourself, did you see 6 patients out of 100 patients this week who have RLS? If you didn't, you're probably underdiagnosing the condition. It's a pretty common condition, and it increases in prevalence over time. This is the prevalence of RLS by gender and age. As you can see, as people get older, there's a greater likelihood of having restless legs, and women are blessed with a higher frequency of the syndrome than men are. Why? We're not quite sure. It could be hormonal in nature. Well, certainly more research needed in that area.
But Carl, can you go back to one slide? As we get older, then there's less RLS. Can you explain that?
Yeah, I think I'm not sure that above 70 or 80 is an artifact. I think where people are basically dying off.
Okay.
So the
So
prevalence
there
is
aren't
getting
as many
less.
people around to have it.
Unfortunately, yeah. You know, the prior lecturer may be able to help us with the lipid control and that sort of stuff and increase that curve, but unfortunately, after 70 or 80, the stats are not that accurate. Now, it's more common in Northern European and Anglo-Saxon type of racial groups. In Western Europeans, Northern Europeans, it's about 9% of the population, so much higher. When you go to places like Southeastern Europe, it's less. Middle East, it's about 3. In Africa, it's like almost 0. But I think in Africa, you have some, reporting artifacts. People don't necessarily volunteer in Africa because they have some concerns about the questionnaires and large pharma companies and so on. The geography doesn't seem to really be a geographic distribution, more of a racial background distribution. And gender, as I mentioned before, it's basically more of a problem with women than men, unfortunately. Primary is much more common than secondary. This is a pie graph showing the prevalence of primary RLS in blue versus secondary in yellow. So primary is where it's caused by no other problems. So if you have, let's say, anemia, you have RLS, that's secondary. But if primary is like it's not caused by something else, that's the much more common form of the disorder. And people who have a primary restless legs are more likely to get it earlier in life and more likely to have a positive family history. So if you're not sure if it's restless legs, you ask, anybody in your family have restless legs? Yes, my mom has it. Yes, my dad, my brother. Boom, you have one hit in favor of a primary restless legs. When did you get it? When I was 17, you got 2 hits for it. Most likely it's primary restless legs. And that's important to know because if it's primary, then you go after the condition, not after its comorbidities as being the #1 therapeutic maneuver. Now, what are some differential diagnostic issues? Well, it's very easy to confuse this disorder with other things. Very, very easy, very easy. I once had a patient I was seeing for what I thought was a chronic anxiety condition, treating with multiple megadoses of antidepressants here and there for 10 years, never got better. Finally, about 10 years, I'm not sure when it was. Paul, when did GSK introduce Requip? About 10 years ago, I think.
But yeah, 10, 12
There
years
were
ago.
these consumer ads, and he came in once with a consumer ad on top. Doc, he said, I got this brochure from a consumer ad that I got. This is what I have. I said, what? You mean restless legs? Yeah, I have restless legs. I said, I've been treating you for 10 years. Why didn't you tell me? He goes, you never asked. And I thought he had anxiety this whole time. It was his legs that were quivering and he couldn't move. So it's very easy to confuse this with another condition. Some people have periodic limb disorder, and that's not restless legs. That's a sleep lab diagnosis. You send your patient to a sleep lab for snoring or something, they come back, and it says their periodic limb movement index is very high. The patient never had restless legs syndrome, never had the symptoms. That's not the same disorder. Treatments are similar, not the same disorder. This is a sleep lab diagnosis where the limbs twitch just during sleep. Patients may not be aware of the twitching whatsoever. These are tough. Peripheral neuropathy and vascular claudication, that sort of thing. Two ways to distinguish those from restless legs. Number one, these things tend to get worse when you move, not better. Restless legs gets better when you move around, number one. Number two, with these disorders, typically there is not that circadian variation. Typically these things don't get worse in the evening, whereas restless legs does. This one is not that hard. Cramps, cramps are isolated. They occur in specific muscle groups. Leg cramps right over here, not both legs, not the entire leg, just a one isolated muscle group. So it's a bit different than restless legs. This one is the toughest. Neuroleptic-induced akathisia. Akathisia. Akathisia is just like restless legs, but it's caused by drugs. And I'll get to the drugs that cause these. These are psychotropic drugs. And there's really no good way to distinguish this other than the fact that, if a patient takes the drug and has the symptoms, then that's kind of a slam dunker that might be neuroleptic-induced akathisia. And anxiety, that's a tough one, as I mentioned before. Anxiety is not limited to the legs. It could be anywhere, motor anxiety, restlessness, but the patient usually has a psychological anxiety as well. So those are things of the differential diagnosis. Okay, depression is very common with restless legs. If you have restless legs, you have a 2 to 4 likelihood of having significant depressive symptoms. Now, why is that? We don't know. But it could be for a couple different reasons. Number one, remember in depression, what are the presumed neurotransmitter abnormalities? Remember that in depression? Serotonin, norepinephrine, dopamine. Dopamine is thought to be a central abnormality in restless legs. So there may be a connection, number one. Number two, depressed people have poor nutrition. They eat less well, iron levels are low, and iron deficiency is one of the potential causes of secondary RLS. Number three, it could be that sometimes RLS can cause depression because RLS itself causes poor sleep over long periods of time and loss of quality of life, like that patient I just talked about. And people have secondary depressive disorders. So there's a very strong connection between restless legs and depression. And if you see restless legs, think of depression, and sometimes you got to treat both to get them both better. How are we doing for a time, Paul? I don't have a watch with me.
You got 13 minutes.
Left, or did I?
Left.
Oh, wow, we better hustle. Okay, good. So, cardiovascular comorbidity as well. There's a very strong connection between restless legs and coronary artery disease. Now, did the prior lecturer talk about that? And restless legs? No. This is not a well-known statistic. There's a strong connection between the two. Now, why is that? We just don't know. But one theory is that with restless legs, as you wake up multiple times during sleep, that sympathetic discharge over long periods of time, the periodic sympathetic activation, causes eventually intravascular changes because of the oxidative stress and may lead to coronary artery disease. Very important data. We'll see more on this coming out in the next couple of years. Now, secondary RLS. What are some secondary causes of RLS? You see RLS, if a patient has multiple conditions, what should you think about, what should you look for as possible comorbidities which you may want to treat to relieve RLS? Well, end-stage renal disease, that's an important comorbidity. Iron deficiency, we'll talk about looking for iron when you have RLS. Pregnancy, a lot of women get RLS. I think it's about 40%, 25%, sorry, get RLS when they become pregnant, and it almost always goes away after the termination of pregnancy. Neuropathies, very important connection, although it's not clear whether it's a misdiagnosis or an actual connection. And finally, Parkinson's and various medications. These are common causes of secondary restless leg syndrome. Now, some medications I mentioned before can cause RLS. For example, antidepressants, a big one. The tricyclics, amitriptyline, Elavil is the trade name for that, typically is Elavil. Mirtazapine, Remeron, the SSRIs. Be careful, if you have a patient who you think is depression or insomnia, you're giving them an SSRI, and their insomnia is worse, I mean, it could be the side effect of the drug, but it could be that you're making RLS worse.
It's interesting, Carl. I mean, depression, you said, is very prevalent with RLS.
Yeah.
So you give somebody with depression, you give them an antidepressant, and their RLS may get worse. So their symptoms may worsen.
Symptoms worsen. So if you see worsening of symptoms with antidepressants, think, is there some underlying syndrome that I'm worsening, and RLS is one of the big potential possibilities. Metoclopramide, I said that right, Reglan, prochlorperazine, sedative antihistamines. Yeah, that's a good one. How many of you prescribe a Benadryl for your patients who can't sleep? You don't have to answer that question, but it's pretty common. Patients take that. Tylenol PM, whatever the PM drugs are out there, the PMs du jour, most of them are antihistamines. Antihistamines worsen RLS. These folks come in after taking these Benadryl PM type drugs and have a worsening of insomnia because they're worsening RLS symptoms. Antipsychotics, quetiapine, olanzapine, Zyprexa, Risperdal. This one, quetiapine is Seroquel. Thank you, Seroquel. Why this happens, we're not quite sure. It could be the serotonin component, we're not quite sure. But you could get a worsening of RLS with these drugs. Calcium channel blockers, H2 blockers like cimetidine. So think of the drugs that patients are taking as potential causes of RLS when you're doing the workup. Now, let's do a next question. What are some of the common RLS misdiagnoses? This is not an ARS question. This is more like a question to probably will ask you.
You want to ask me?
What do you think?
Well, I never misdiagnosed it, Carl, because I learned everything from you. No, but honestly, I mean, one of the things that you said is the whole idea, and I'm going to expound on it, is fatigue and tiredness. People come in saying that they're tired all the time. And we don't really think about the fact that it could be a sleep problem, and we certainly may not even think about the possibility that that sleep problem is RLS. So one of the common RLS misdiagnoses, we may misdiagnose them with tiredness, fatigue, depression, insomnia, that sort of stuff, but we haven't asked the right question to get us to RLS.
That's impressive how and in most cases they don't even tell us, which is impressive.
So we have to be on the lookout for it. You said how prevalent it is,
Yes,
RLS.
it's extremely common. Now let's talk about the etiology of restless legs, and the right answer about etiology is we don't know what causes it. But there's some hypotheses, and one of them is that, and by the way, the original syndrome described by Karl Ekbom, who was a German neurologist, I think he was German, who described it. About 25 to 30% of the patients had iron deficiency. So he thought iron was an important cause of RLS. And in fact, getting iron levels is an important part of the workup of RLS. If iron is involved, what's the dopamine-iron connection? Because dopamine is thought to be the neurophysiologic mechanism which causes RLS, although there's controversy about that as well. Well, iron is a cofactor in this rate-limiting step of the conversion of tyrosine to dopa and eventually to dopamine. So if you don't have enough iron, you're not going to produce as much dopamine and potentially, conceivably, theoretically, contribute to RLS. So that's one of the potential connections between iron deficiency, dopamine lack, and RLS, although as I mentioned to you before, this is an area of active research and there's not a great deal of confidence in some of these theoretical formulations. Now, there are a couple of studies which allude to the iron issue. For example, if you look at the prevalence of RLS among anemic patients, about 34% have RLS, whereas only 6% of non-anemic patients have RLS. So anemia is a common comorbidity and contributor to RLS. Number two, this was a very nice study, double-blind placebo-controlled study. If you give iron to people who have RLS and have low ferritin values, low ferritin levels, often you produce symptomatic improvement. This is the IRLS scale, a scale of restless leg severity. And if you give iron, you notice that the RLS scale shows diminution of symptoms after 12 weeks in patients taking this versus placebo. So iron supplementation can be important in the therapy of RLS, and we'll get to that in a couple of minutes. Again, nailing the potential connection between iron and RLS. So what's the workup? Let's say a patient comes to you, I can't sleep. Do you ever have your legs bother? Oh gosh, yes, my legs, I can't go to sleep. They bother me, they twist and turn, and so on and so forth. Well, what's the workup? Well, first of all, do a physical exam. Exclude the neuropathies, exclude the secondary causes, any signs of anemia. Did you get a CBC on this patient in the past 6 months or year or not? Did you get maybe metabolites? You may want to give Renal metabolites, very important because of the potential connection between renal failure and RLS. So get a good workup. Number 2, exclude the effects of medications. Look for the antipsychotics, antidepressants. Make sure that's not what's going on. Number 3, check your iron levels. Check your ferritin levels. Do a serum ferritin. Serum ferritin is easy to do. It's a cheap test. And your lab normal may be 20 and above. In RLS, it should be, I apologize, lab normal may be 20 and above. In RLS, the cutoff threshold is 50. So anything below 50 is abnormal, and Paul will go over this later on, but those are the people in whom you initiate iron sulfate therapy. We'll talk about that in a couple minutes. So get a ferritin and look at the medications and so on. And also, in terms of therapeutics, Paul will talk more about this, you really want to think about lifestyle improvements before you jump to pharmacology. We'll talk about that in a couple more minutes. So, in conclusion, RLS is fairly prevalent. I hope I've impressed you with that. And it's impactful. People suffer from it unknowingly. Number 2, it affects their sleep and quality of life. Number 3, it overlaps with a number of other conditions which may be contributors to RLS symptomatology or even the pathophysiology of RLS. And iron and dopamine are the 2 systems that are critically involved, we think, in the genesis of RLS. Paul, I'm going to hand it over to you.
Good job, Carl.
Thank you.
Yeah, that was good, wasn't it? Okay. All right. So just a little bit of a background for myself. By the way, who's older, him or me? Don't answer that, because you may get it wrong. A little bit of a background. I mean, I'm a family doctor. I've been that for 27 years. And Carl, many years ago, came to me on a number of occasions and said, "You family doctors don't get it about sleep. You don't put enough importance on sleep, and you need to do that because it's such a critical aspect of life. We always talk about how important exercise is and good diet is and that sort of stuff. We don't talk about sleep enough. And interestingly, it's exactly that. And we family doctors, don't get enough training in medical school or even residency on sleep, Carl. We just don't, and we do need to do that.
See, this is one where, Paul, I had it right?
Very rarely, but I'm only admitting it here in front of these people. But again, the thing is, we need to know about that. And one of the critical aspects of understanding a person and their sleep is that they don't talk to you about it until it's very, very bad. I mean, there's data that shows that people just with insomnia, okay, 75–80% of the time, they'll never mention it to you. And about 10–15–20% of the time, they'll only tell you about it on the doorknob. They're going out, by the way, what do I do about my sleep? But it's very rare that they come in and say to you, I have a sleep problem. And it's even rare that they say, I have a sleep problem, it's restlessness in my legs, and I think I have RLS, just like that patient that you said he needed a pamphlet to come to you with.
Right.
We need to be on the lookout for it. So one of the things that we need to do is to heighten our level of awareness that something could be going on with a patient's sleep. Just for laughs, what you may want to do is for the next couple of weeks, when patients come in with anything wrong with them, ask them about their sleep. How are you doing with your sleep? I ask that on just about all of my patients at some point in my encounters with them over the years. I'll ask them about their sleep. Certainly during a complete physical examination on the review systems, I'll always ask them, do you have any trouble getting to sleep? Do you have any trouble staying asleep? How's your energy throughout the day? I'll always ask them, and you'd be surprised what comes up with people. You need to do that. So these are some of the screening tests. How is your sleep? Do you have trouble getting to sleep and staying asleep? And again, do you have any trouble during the day? These patients with RLS will complain of tiredness. They'll say, I'm tired all the time, okay? Folks, that is a very general term, okay? And don't assume you know what that word tiredness means. You have to analyze it. I'll ask my patients, well, when you say tired, do you mean fatigued? That is, you don't have the energy to get going, you have to rest a lot? Like in patients with congestive heart failure, or with asthma, or with anemia, or that sort of stuff. They walk a little bit, then they have to rest. They may say they're tired with that. But also the patient who doesn't sleep well. For example, if I ask you to shave off half your sleep tonight, tomorrow you'll wake up and you'll say, I feel tired. And you'll say, I feel tired all day. You don't have CHF, anemia, asthma, that sort of stuff. You just didn't sleep long enough. But you'll still say tired. You know it's a lacking of something. And don't assume that you know what your patients mean. Ask them a little bit more. And that's where getting a good history is so important when patients say they're tired all the time. Okay? More than anything, if they're going to complain of anything, as I said, it's going to be tiredness. Sometimes they'll say trouble sleeping, but more often they'll say they're tired. Now, one of the things that you don't want to leave out is interviewing the bed partner. Now, sometimes you don't have the luxury of that, okay? Sometimes I'll even ask my patients, what does your spouse say about your sleep? Oh my God, my spouse doesn't even sleep in the same bedroom anymore because I blankety, blankety, blank. I snore my head off, or I kick him all the time, or that sort of stuff. You know? It's important to ask then sometimes about the vet partner. If they're there, they can give you valuable information. As far as laboratory evaluation, folks, RLS is a diagnosis that you make by asking patients. You don't need any blood tests. You don't need a sleep lab. You don't even need him. You just need to ask, well, I don't mean that in that way, Carl.
Thank you.
You don't need a sleep laboratory to make the diagnosis. You simply go through the URGE, U-R-G-E. You know, you have trouble getting to sleep, and maybe even staying asleep, but trouble getting to sleep, and what causes it is a discomfort in your legs that worsens as the night progresses, and the only thing that really gives you some relief is movement. Okay, and that's all you need. Once you establish that they have RLS, then you have to establish whether it's primary or secondary. Now, as Carl said, the majority of people, they're going to have primary RLS, especially if they come at it at an early age in their lives, okay? But you don't want to miss secondary RLS. And here are some of the tests. You want to make sure they're not anemic, but keep this in mind. A CBC alone is not enough, because a lot of people who have RLS that's secondary, okay, have low iron levels, but normal hemoglobins, okay? And as Carl said, remember, this is a very important pearl point, okay? And that is, they're very sensitive to low ferritin levels. So levels below 50 can cause symptoms. As opposed to your laboratory, some laboratories will say levels below 12 is abnormal. No, it's 50. They're very sensitive to low iron. So you want to get a CBC, but also a serum ferritin. Transferrin I usually don't get. It's an expensive test. It is sensitive and specific, but I usually limit it to CBC and ferritin for just myself. But as far as a comprehensive metabolic panel, what are you doing there? You want to rule out diabetes, okay? Because sometimes they have peripheral neuropathy. You want to make sure they don't have chronic kidney disease. So getting a comprehensive metabolic panel, that's pretty much all that you need for RLS. Okay? They may want to do other tests, et cetera, if they're coming in for a physical, but for RLS, those are the blood tests that you want to do. Well, also maybe a pregnancy test, Carl, in women, right?
I guess, well.
Especially if a woman comes in with a big belly. Are you pregnant? I'm not sure. It can happen sometimes, right? All right. So let's go to a case study. Carl mentioned a whole bunch of case studies. Let's go to a specific one. Here's Sally. She comes to your office, says, I am having the hardest time sleeping lately. Okay? And interestingly, sometimes, as I said, people will do that. Women more often than men will actually complain of sleep problems. I toss and turn all night, and I just can't fall asleep, and I think I have insomnia. Now, she's already leading you, you know, that she has insomnia. You need to ask more questions, okay? So here's some of the history on her. She's 78. She's widowed. One son, currently lives in a senior community, independent, active in church. She lives more than 8 hours from her family, and she was diagnosed with depression a year ago. She takes fluoxetine. Remember what Carl said about secondary RLS? It could be from antidepressants, okay? So already the wheel should be turning. She takes a multivitamin. She takes iron. Wow. She takes iron, so maybe the iron isn't going to be an issue here. Her physical exam is essentially unremarkable. So here we have a woman that comes in saying she has trouble with sleep, and she feels tired all the time. What additional information would help and differentiate? Hopefully, here's what you're thinking. I need to know more about her sleep. How long has it been going on? Okay, and how long does she toss and turn? Does she wake up in the middle of the night? How tired does she feel throughout the day? This is a sleep history that you need to get from this woman. And it will clarify for you what's wrong with her. And especially you want to ask, if you have trouble getting to sleep, is it because your legs are uncomfortable? Okay, now again, it's important that I stress this, because sometimes patients won't tell you that. They say, yeah, you know what, come to think of it, my legs do bother me. And in fact, when I'm sitting at the TV with my spouse, not her because she's widowed, you know, I kind of move around and my spouse gets upset at me that I move around, so he goes to another chair. You know? So ask that question. I specifically ask my insomnia questions. Do your legs bother you and give you problems? Do they interfere with you falling asleep such that the only thing that relieves it is when you move your legs? That's kind of important to ask her. So anyway, a little bit more about her history then is, look at this. She wakes up at 5:30 and every morning. She goes to church and she has a work job there. She has dinner at 5:30. She goes to bed at 10:30. Pretty much the same thing on weekends as far as when she gets up and when she goes to bed. And the symptoms occur almost daily with difficulty falling asleep and sluggishness. I would have also wanted to know, again, how long has this been going on and what's your energy like during the day? Carl, most people with RLS do complain that they're tired throughout the day, right? Isn't that what you said earlier?
Most of them are tired, exactly. And you know, some will say they're just fatigued all day long. Some will actually be falling asleep during their activities as well.
They're actually drowsy.
Drowsy, sleepy.
Folks, that's a very important point. Use these words: sleepy, drowsy, okay? And another little pearl for you is this. You know, when you ask them about drowsiness, are you tired when you sit and do nothing versus are you tired when you're jogging? Okay? And sleepiness gets worse when you're doing inactive things, okay? And that's an important point as far as asking somebody about sleepiness, okay? So now what's the first item of treatment that we would want to do with anybody? Okay, if somebody comes to your office with diabetes, hypertension, cholesterol, is the first thing they do put a pill in their mouth? No. You educate them on the condition. You tell them what you think is wrong with them. Have them buy into the condition. Wow, it's RLS. Yes, and this is a sleep problem. And in order for your sleep to get better, you need to cooperate with me and do several things. Okay, some of the important things about good sleep is good sleep hygiene. Okay, and it's important that you know this, and you probably do, but going to bed at the same time, waking up at the same time is very important. Getting long enough sleep, 8 hours at night, I mean, for average or plus or minus. So sleep timing, sleep duration, and sleep quality are very critical. And to make the duration, timing, and quality good, you also need to be, you need to coddle your sleep, okay? Or you need to respect your sleep. You need to make your situation sleep-friendly for at least the hour or two before you go to sleep. So don't be doing very active things right before bed. Don't be arguing with your spouse or watching TV or exercising or that sort of stuff. It's not good for sleep. So there are a lot of things that are sleep-friendly. There are a lot of things that are sleep-unfriendly, and you need to do that. And let me also highlight as far as nicotine, alcohol, and heavy meals and that sort of stuff. You need to educate your patients on this. There's a lot of things that they can do to make their sleep better. Right, Carl?
Well, if I just mention something about this, first of all, it's a very difficult thing to do all this, isn't it? In the context, especially of primary care, busy practice.
Yeah, but we have a lot of time, though. We see patients many times.
That's a good point, but
Yeah.
do people actually take the time to take the time to do these things with their patients? Because it's so important. You know, we have people taking, you know, caffeine all day long and drinking a cup of tea at bedtime. They can't sleep, and we run to give them a sleeping pill. But these are such important you know, strategies, and do we in fact do this, do you think?
Again, I used the analogy of a patient with diabetes or hypertension or cholesterol. You need to educate them not just on the condition, but all the things that they can do to make things better. Here's all the things that anybody can do about their sleep to make some improvement. Okay? So as far as the RLS treatment, you know, as Carl said, you know, first you want to make sure about whether it's primary or secondary, and if it's secondary, certainly you want to treat that. Okay? But again, you don't jump to pharmacologic measures right away. There are alerting activities you can do. At nighttime, for example, maybe they do a little bit more active things, okay? Or like maybe they take a little bit of a walk right before dinner time, okay? That would be a better thing to do. And do the inactive things in the morning when things aren't bothering them that much. Iron replacement all the way at the very end, only if there is iron deficit, okay? Don't just give people iron just like that randomly without knowing what their serum ferritin is. Okay? And now modifying the doses of drugs that may enhance RLS. If somebody has RLS, like in this woman, Sally, she's already taking an antidepressant. We may want to think about whether, you know, about the benefits and risks of that medication in her situation. Okay? And again, as far as caffeine, nicotine, and alcohol. Now, as far as pharmacologic methods, look at the blue parts. You know, RLS can actually have various degrees of severity, and as such, it may guide you as to what treatments that you may use. For example, RLS may be intermittent. It may not happen all the time. And it may be daily, or sometimes it's refractory. It's really severe. Now, for patients that have intermittent RLS, you have the list of 4 medications that are. I'm going to go over all the medications in detail on the next slide. But also, for daily RLS, we don't necessarily want to use opioids on a regular basis. But when there's refractory, the point to be made there is sometimes you want to not just use high doses, but combination medication. Okay? That's the main thing there. So as far as RLS specifically, behavioral and lifestyle changes, distraction techniques, you know, sometimes if they do things to distract them in the evening, changing the temperature, both cold or hot. Take a hot shower. That made things worse. Well, take a cold shower. Maybe that'll help, you know, or a cold bath or something. Temperature changes. Exercise activity later in the day, but not too close to bedtime. Like I said, all right? Massage, if you have a spouse. Sally doesn't have a spouse. Maybe she can go across the hall and ask John, who's also a widower, or maybe, I don't know, whatever. They can massage each other's legs. And relaxation therapy and also acupuncture. Carl, there aren't really any good studies with acupuncture,
Not
right?
really. It's a very tough thing to control acupuncture because there's no active control mechanism. No, I mean, controls or double-blind placebo-controlled type of studies require something that people don't know is the active therapy. And acupuncture is hard to fool people which is the active therapy and which is the inactive therapy.
Yeah.
So there are no good therapies with acupuncture, and the studies aren't all that impressive. But you know, some people have tried it, they claim it works.
Yeah.
The other thing that's interesting is the distraction techniques. I tell people sometimes to play video games in the evening, to take their minds off of RLS, because you find that what they do is they're waiting for the symptoms to happen, and they're so tight and anxious about it that it makes the symptom come along. So if you can get them away, think away from about something else, it sometimes distracts them from
It may be hard for Sally, who's 80 years old, to play video
play
games.
video games, right?
Maybe
But there is a Wii version for seniors. Did you know that?
Is that right?
There is, yes.
Well, we don't qualify for that, right? Okay. Now, again, as far as non-pharmacologic methods, there's actually been studies on cognitive behavioral therapy, and there is a modest improvement with CBT. It's not that much, Carl, but I
No.
mean, it can help,
Yeah,
right?
it's modest.
So if you like cognitive behavioral therapy, or there's a sleep lab close to you who has a therapist like this, you may want to have them get involved if you don't want to use medication, or if your patient is resistant to taking medication. So let's go back to Sally. So what happens is we say to Sally, here's some of the things that you can do, okay? And we go through all the different measures. Massage, hot and cold shower, avoiding symptom triggers, and maintain good sleep hygiene, and schedule a follow-up appointment. So how effective are non-pharmacologic treatments for RLS? Carl, I guess, I do that, and they come back, and they may improve a little bit, but not too much.
Not too much. And the other thing is, so you sort of think, well, if they're doing a lot of poor sleep hygiene, maybe if I do use medications, the medicines may not be as effective as if I were to use sleep hygiene.
Yeah, and again, most patients don't necessarily want you to give them another pill.
That's correct.
So, I mean, you want them to really try non-pharmacologic methods. And the last question, when would you bring them back? Whenever. A week, 2 weeks, a month, whenever they're ready to go on, let's say, medication. I would tell Sally, look, try all these out, see how things work for you. And if they do, terrific. But if they don't, and you're pretty much frustrated with them, come on back and let's see how things are going. But don't wait too long, of course.
Paul, question, would you ever play around with a fluoxetine dose? Remember, she was on Prozac here.
That's a good question.
What do you think?
I think one of the things I would see is how long has she, well, she's been on it a year, how long has she been in remission, if she is in remission?
Yeah.
If she says, you know what, I took the medication for about 2-3 months, I started feeling fine, and doc, for the last 9 months, I've been feeling fine. And it may not be a bad idea at that point to say, you know what, Sally, let's also do one other thing. Let's wean you off the fluoxetine and see if things get better. That's a very good point. So she comes back to you and she reports no improvement, and you did the right thing by getting some lab studies, and her serum ferritin is 134, which is pretty high. She's really doing well with that iron. I wonder why she's taking iron. But anyway, there's her iron and their iron binding capacity. She's doing fine. So it's not a secondary cause. And I'll also tell you that all the other parameters were also okay. So again, what serum ferritin levels should prompt you to consider it? We've already talked about that. The magic number is 50. All right. Now, as far as the medications, okay, there are non-ergot-derived dopaminergics. Pramipexole, ropinirole, rotigotine, and levodopa. And on that list, the fourth one does not have an FDA-approved treatment for RLS, but oddly enough, before the first 3 were available, the only thing that we did use was levodopa-carbidopa combination.
Cinemats, correct.
We still use it, though, don't we?
We still use it, but not as much.
Yeah,
more
because these
side
other
effects.
agents work so well, and they're once a day, and they do a pretty darn good job. And again, the first 3 are approved. There are the dosages there. You probably pretty much know about them. I'm not going to go over them in detail. The interesting thing, though, is that the first 2 are pills, and you give them primarily in the evening before the symptoms start. But the third one is a patch. Okay, and it's a patch that's worn. Carl, I guess you can put that on anytime, right?
Yeah, typically people do it in the morning, though, right after they shower, because they shower, they take the patch off, they shower, and they put the new patch on because the skin is clean.
It's a once-a-day patch that you put on, and it's interesting. It works quite well. And again, like I said, the first 2 are oral agents. Now, interesting data that we have on these dopamine agonists, okay, for moderate to severe RLS. We have data on pramipexole and ropinirole and rotigotine, and like I said, the third one is the patch. Now, look at this. The placebo, after 3 months, okay, now these are responders, 3 months responders. Placebo works great. Placebo is a great drug, I guess, isn't it? It works really well. I mean, look at this. Almost 50% of people said that they did quite well with placebo. But what I want you to look at is the placebo minus active column. Let me point, I guess, over here. Placebo minus active and placebo minus active. This is 3 months and this is 6 months. And this is pretty much probably the best way to ascertain how well the medication is working. Yeah? And there's a substantial amount of responders. These are people who said, I got better or a lot better or a whole lot better with medication. These are the responders. So there's a good bit of 3-month responders and 6-month responders with both medications. Okay? And actually, there's even a study here with even longer duration A 5-year study with rotigotine, which is the patch that I mentioned, no data on long-term 5-year for the 2 pills that are available. But rotigotine, again, look at this. The responders, 96%. Now, again, for the 1 year, the responders is pretty high as well. So these medications work quite well. They seem to do very nicely for a year, 5 years, Carl. That's a pretty long study for this.
It's impressive, and it's important data because, you know, this is not a condition, as I mentioned before, that goes away. It's a chronic condition.
Like you said
chronic
earlier.
therapy is going to be the norm for many patients. So it's good to have this information.
Absolutely. And like I said, these medications work very well, and they'll work pretty quickly. But again, if you refer to the slide on how to dose the medication, for the pills, you do have to gradually escalate the dose. Now, for the patch, you can escalate the doses as well, but there aren't as many dosage escalations involved in there. But for the pills, Carl, I guess after 5 days, you would gradually increase the dosage, right?
Yeah, I mean, that's a good rule of thumb, I think, yeah.
Until you reach the desired benefit. Okay, here's a question for you guys. After initiating Sally's treatment with a dopamine agonist, whichever one you chose, how long would you wait to assess treatment efficacy? How long would you wait? Okay, would you wait 2 weeks? Would you bring her in 1 month? Would you bring her in 2 months or 6 months? Or I guess item 5 would be never, but we don't have that there. So go ahead and put in your answer, please.
I'll have to push the button. No music.
No music, that's okay. You want to hum? All right, whoops, let me go back. Oh, what happened? Most people, well, I think it was most of them were at 1 month. Wouldn't you say?
Yeah,
Oh, there it
is,
is, there we
there
go.
is, yeah.
70% of you said about a month or so. I think you'd be right if you said 2 weeks or if you said 1 month. 2 months I think would be too much, okay? Unless you don't really like Sally too much. But anyway, 2 weeks or about a month I think would be about right, okay? I may even call her, okay? I may even ask her to call me, you know? Take the medication, gradually increase it, and call me and let me know how you're doing in a couple of weeks, okay? I may even ask her to do that, and then come back and see me in about a month or so. Nothing rigid and written in stone, but you don't want to wait too long is the main concept that I want to get across to you at this point. Okay, another one. After initiating treatment with dopamine agonist, how would you restructure treatment if the patient reports breakthrough symptoms during the daytime? So in other words, you gave Sally the medication and she says, yeah, I'm doing okay. But a while later she says, you know what, I'm having some symptoms during the day. So would you increase the dose of the initial dopamine agonist? Would you switch to a transdermal formulation? Would you switch to a non-dopaminergic medication? Or would you say, I've had it, I'm just going to refer to sleep lab? What would you do? Go right ahead. So most of you would increase the dose of the initial dopamine agonist. I think it's fairly
It makes a lot of
reasonable.
sense. Yeah,
sure.
optimize therapy first before you do anything else. Yeah.
And some of you would switch to a transdermal formulation, which is good thinking because a transdermal formulation is just once a day, and the medication is going to be on board throughout the time. The other medications have shorter half-lives.
Yeah, they go in and out within a few hours, so typically you need a second or third dose during the day to keep that sort of blood level up throughout the course of the day.
But a lot of patients with mild, even moderate RLS just have it at night, and during the daytime they're fine.
Right.
So using a shorter acting medication like a pill that they take right before their symptoms start in the evening may be sufficient. But again, for those where the symptoms worsen, remember what Carl said, as the years go on, the condition is going to worsen just by nature. So you may need to do some things like increase the dosage, or what some of you even said, give a dosage in the morning, or even maybe use a once-a-day medication. Carl, only 1% would refer patients to you.
Yeah, well, that's okay, you know, because we're pretty busy. That's okay. Don't worry about it.
All right. Now, interesting thing about dopamine agonists, they have this impulse control problem, okay? So look at it, 7 to 17% of RLS patients using dopaminergic medication report impulse control problems, okay? And like hypersexuality, I'm not sure how Sally's going to be doing that, but anyway, punding, look at what punding is. It's a compulsive fascination with and performance of repetitive mechanical tasks, such as assembling and disassembling, collecting, or sorting household objects. Weird, isn't it?
Yeah.
Punding,
Yeah.
interesting word. You know, pathologic gambling. That could be a problem, and all the way down to, again, any impulse control disorder. So this can happen with your patients. Be on the lookout for it. Carl, if that happens, I guess you have to switch them off those kind of medicines and use a different category of medicine.
That's what I would do. Absolutely. And the important thing is, I think I've said before, maybe warn them ahead of time so they know that it might happen. So if it does happen, at least they give you a call. Don't think it's a normal
Or the other way of looking at it is don't tell them, because then they may say that they have it and come and say I have impulse control problem. So anyway, yeah, but I think warning them on side effects is important with any medication. This isn't any different. So there are non-dopaminergic agents as well, so that when the dopaminergic agents have a problem with them, you can go to some of these. Now, gabapentin itself is not FDA approved, but gabapentin, I always forget this word, enacarbil, okay? This is a once-a-day branded medication. I'm not sure what the brand name is, Carl.
the enacarbil.
When you think of it, let me know.
I'll think of it in a second.
Okay. So it's FDA
Horizant. Sorry, Horizant is a trademark.
Horizon?
Same thing, right.
Potato. Okay. So again, it's FDA approved. It's just one dosage, right? 600 milligrams once a day. And that's a pretty decent medication to use in patients where you want to have a non-dopaminergic agent. Pregabalin, again, not FDA approved. Opioids, not FDA approved, but they can really work well, Carl, opioids, right?
Yeah, they can. It's tricky to use them, in a chronic setting, because they have to be refilled once a month, and people obviously there's an abuse potential there.
Yep.
So it's something we don't want to go to quickly, but it's certainly something we can fall back on in a refractory case.
Exactly. Right? Now, a lot of these medications, both the dopaminergics and dopaminergics, are generic medications. There are generic formulations, so if that is an issue, the cost or generic, you can go to them. So that's a good thing as well. So rebound and dopaminergic agents. Rebound can happen, and this is when the medication is wearing off, you get really escalation of symptoms. And generally this happens later on in the course. You've treated somebody like Sally for several months, maybe a year or so. She says, you know what, in the mornings I'm starting to get symptoms, and it's even happening worse than it was before. So the medication is wearing off and you're getting rebound of symptoms. And this occurs more often with shorter acting medications, and the treatment restructuring may include reducing the dosage of the provocative medication so that you don't get a rebound effect. So maybe you lessen the evening dosage. Now the problem with that is the RLS symptoms may worsen, but again, you don't have as much of the shutdown of the medication causing rebound. So maybe that'll work for you. I'm not too much of a fan, Carl, of reducing the dosage. Yeah. Switching to an alternative dopaminergic medication with a longer half-life may be a better idea. I think it's a better idea. And using drug combination may not be a bad idea either with a lower dopaminergic agent. So whatever dopaminergic agent you're using, you lower the dosage and use another medication on top of it, so that you're not going to get the rebound from the dopaminergic medicine, but you're also covering your RLS by giving him one of the other non-dopaminergic medications. These are some of the things that you can do for rebound and of dopaminergic agents. Now, augmentation is something else. Augmentation means that as the years are going on and the RLS is getting worse and you're giving more and more medication, you've maxed out on them, all of a sudden their RLS starts to get worse. They're getting RLS symptoms, and now it's in their upper limbs, and now it's occurring earlier on in the day. And this happens to be some kind of an idiosyncratic response to the dopaminergic agent itself. We're not really sure why it happens. So be on the lookout for that, especially in those patients where you've been using dopaminergic medication for quite a while and they start complaining again of worsening symptoms during the day, earlier on in the day, and moving up to the arms, okay? And if this happens, you want to think of the possibility that this is augmentation. And interestingly, it happens a lot more with levodopa-carbidopa combination, and a little bit with pramipexole, a little bit more with ropinirole, and the least of this occurs with rotigotine, which is the patch that we talked about. So some of the things that you can do with augmentation, some of the choices, I guess, one of the things that you may have to do, Carl, is to take them off a dopaminergic agent.
Yeah, if it gets that bad, they're maxed out on that drug, then they're having augmentation, you really have to get them off, but very slowly. That's the trick.
And at the same time, using another medication to take the place of the dopaminergic medication. So let's go back to Sally. So how would you restructure treatment if the patient experiences rebound or augmentation? Well, let's first of all, again, review what we would do with rebound. Okay? You may want to use a longer acting medication. You may want to reduce the dopaminergic medication and add another medication that's non-dopaminergic, or again, use a longer acting dopaminergic medication. For augmentation, probably the best thing to do is to wean them off their dopaminergic medication and add a non-dopaminergic medication, going very slowly as you do so. Okay, so a little bit different with one and the other as far as, again, rebound and augmentation. Inadequate or rather intolerable adverse events. Some people just can't tolerate some of these medications. Especially as we talked earlier, all these dopaminergic medications can have some side effects. And again, augmentation that is not controllable with additional earlier dosages of the drug. So, Carl, in refractory situations, we have a couple of options. We can go to gabapentin, and it's not a bad idea. It was off-label, but the gabapentin, the one that we talked about, the Horizon, that one is on-label as a gabapentin. Change to another dopamine agonist or gabapentin enalapril, that's the one there. Add a benzodiazepine. How about that? We can add a benzo.
We used to use a lot of benzos in the past. They do work sometimes, yeah.
So, Carl, in 20, 30 years ago, well, you were practicing then, right?
Right, yeah.
So in RLS, you didn't have all these dopaminergic medications. I guess you used a lot of levodopa, carbidopa.
Benzos and opioids, yeah.
Benzos and opioids.
Yeah.
Well, what's the benzo of choice? Any specific one?
Well, typically people use clonazepam, but any benzo is really as good as any of
Do
them.
they need a low dose or a high dose of them?
You start low and you go slow.
And
Yeah,
gradually
yeah,
increase.
yeah.
Okay. And opioids, is there a specific opioid that's better than any other?
Whatever you like to use. Any opioid pain medications are fine. Yeah.
Oxycodone, hydrocodone, codeine,
Some
morphine?
Some people can go to morphine sulfate, yeah.
Okay. All
Again,
right.
off-label stuff, and you don't want to go there as your first agent, but in refractory cases, sometimes you have to.
And even high-potency opioid,
Right.
like we have at the very end. Again, in some patients, you have to do that because all else has failed. And these are refractory patients. These are all else has failed patients. All right. When to consider referring to sleep clinician? Well, it depends on how close you are to sleep clinician or a sleep laboratory. By show of hands, how many of you have pretty easy time referring patients to a sleep specialist?
Everybody.
That's pretty good.
Yep, good.
That's
Terrific.
great. So when you get to a point where you've tried 2 or 3 things, or you get to a refractory situation and you're not sure what to do, I think that's important. But another thing that you want to do is this: in patients who are complaining of tiredness throughout the day, and whether you've ruled in RLS or ruled it out, if they continue to have tiredness throughout the day, they could have another cause of sleepiness. They could have RLS and obstructive sleep apnea. They could have RLS and periodic limb movement disorder. They could have RLS and a number of other things that could cause or be a problem during sleep. Isn't that right, Carl?
Yeah, as a matter of fact, we have some nice data showing that if people have RLS and OSA or sleep apnea, when you treat the apnea, in about 50% of cases, the RLS goes away, which is really interesting.
How about that? Any reason? Any reason for that?
I think sleep apnea is such a tremendous stress to the entire body, especially the hypoxemia, that it induces RLS because of possibly a CNS insult. Yeah.
Okay.
Yeah.
And again, unusual behaviors during sleep. Unusual behaviors.
Parasomnias, yeah.
Patients who whack their spouses in their sleep. In their sleep, okay, not while they're awake. That's a parasomnia. That's not a good thing, or other kinds of unusual behaviors. All right. Suspicion of narcolepsy, and like we said, obstructive sleep apnea. So our conclusions: RLS is a neurologic disorder characterized by an irresistible urge to move the extremities. Remember the mnemonic URGE. RLS diagnosis is frequently missed in clinical setting because most patients don't come to you saying, my legs are uncomfortable at night. They'll come to you saying they're tired. So you have to specifically dig into it. Don't forget it. Put it high on your index list. Put it on the radar. Okay? Patient's assessment should exclude other diagnoses, other disorders, and establishment of the subtype of primary or secondary. So when somebody rules in for restless leg syndrome, make sure you rule out secondary causes. Treatment entails the effective management of the comorbidities, like if they have a secondary RLS, promotion of proper sleep hygiene. You have to have them buy into it and do things that are sleep-friendly, and then use pharmacotherapy when the time comes to do so. If conservative measures are not effective, various pharmacologic formulations that are available on-label and off to individualize the treatment. So that's pretty much all that we have to say to them. This is our story, and we're sticking to it. We have a couple more minutes. Is there
I think he did a good job too, don't you think?